We'll move on to another part which we should definitely spend some time on is the whole concept of the antiangiogenic as well as the TKIs. And I'll start by saying that the whole story, if you recall, started with sorafenib. And at that time, the understanding was that actually it was a anti-RAF, and if anything, later on it was kind of, acknowledged to be a rather soft, not necessarily the strongest of an anti-angiogenic, but there definitely was an anti-angiogenic component. Now, later on in the game, however, other trials came on board after really a lot of effort for getting other studies that were sadly all negative, until we came to this new era in the last 3 years, as I mentioned in the beginning, and we have the new drug called lenvatinib. So let's ask Tim. So lenvatinib, tell us, what's lenvatinib?
So lenvatinib is another multi-tyrosine kinase inhibitor that is initially thought to be was used in other cancers and then tested also in HCC. It has a stronger vascular component, or antivascular component, I should say, than the sorafenib.
Fair. And Mike, lenvatinib, anything intriguing in regard to the response that we can talk about, especially compared to the sorafenib per se?
Right. Well, in the REFLECT trial, there was a higher response rate. Now, it's important in reviewing the literature to realize that both modified RECIST and RESIST are used in different clinical trials. The top-line data used modified RECIST. There was about a 42% response rate based on that, which is certainly something we were not expecting from sorafenib. There can be responses, but not quite as often.
Fair enough. So it's good that at least we have two choices of therapy now, being the sorafenib and the lenvatinib in first-line therapy. But then to go back to the sorafenib for a second, Catherine, it came a little bit of a surprise first, but now we are getting a better understanding. Regorafenib with the conditional prior sorafenib exposure and tolerance. Tell us a little bit more about that story with the resource. Yeah.
So the resource trial was the regorafenib in second line, and it was specifically studied in patients who had previously tolerated sorafenib. So really trying to ensure that the tolerability and the ability of the patients to tolerate that second line TKI. So the patients had to have tolerated sorafenib at least 400 milligrams a day for at least 20 of the last 28 days. And then they were enrolled and randomized to Rego versus placebo. And we did see an improvement in overall survival in that study. And there was the very interesting publication from the survival from the start of sorafenib to death was 26 months with that combination. So really, a breakthrough in terms of the survival that we can expect with systemic therapy. I think it really just emphasized the need to maintain liver function in these patients so that they can receive multiple lines of therapy.
No, by all means, if anything, now we have at least a theoretical thought that probably the resistance to sorafenib is actually led by certain activation of FGF, and that probably is a better target, and IGF, which are better targets for regorafenib than it is for sorafenib. But with this said, we'll go back to Ricardo. So you had a lot of experience. Actually, you led a lot of efforts in regard to sorafenib in combination with the chemoembolization. And tell us a little bit more about the idea of putting a TKI with the embolization. Your thoughts on that?
Well, one of the issues with chemoembolization is in reality that the creation of hypoxia in the tumor microenvironment is good because, of course, one of the mechanisms is ischemia. However, on the other hand, this is known to upregulate several mediators involved in angiogenesis, such as hypoxia-inducible factor 1 alpha and VEGF. So the idea to look for a synergistic effect from chemoembolization plus a drug that would be able to mitigate or prevent this neoangiogenic switch, which clearly is eventually facilitating progression, was investigated in several studies. Clearly, many efforts looking at the combination of TACE and sorafenib versus TACE alone, but also investigating other drugs, including bribanib or antinib. Unfortunately, the bottom line is that what looked like a nice mechanism based on preclinical data didn't really result in a meaningful effect, and therefore this kind of combination was not really having such an impact in the clinical management of
We'll hold that thought, because you're bringing a very important point, because as you suggested, you were the first actually to do a combination of the TACE plus the sorafenib, and there are many other efforts per se, and as you said, they were negative. But we'll hold that thought, because definitely we're going to come back to it in regard to other potential combinations per se. Sure. But before we go there, let's go back to the use of the TKIs, and especially in second line. And Tim, cabozantinib, tell us more.
Yes, cabozantinib is actually a very interesting drug because it's a c-Met inhibitor, and there was I don't want to bore you with all the details, but there was a lot of interest because there was some data, lot of preclinical data, but also data from biopsy that c-Met plays an important role. There are certain groups that may respond better than others. Now, in the end, we have to say this all never really played out. We had all the signs, but in the end, it's basically shown to work in the second line as an effective drug, and it's really the first, I would say, sorafenib-like, because regorafenib and sorafenib are very similar, like drug, which is another pan-TKI to be shown very effective in the second line setting.
Yeah, so I like what you said. And interestingly, historically, before the advent of the checkpoint inhibitors, all what we were busy with was c-Met, because the liver, the hepatocellular growth factor, which is a receptor for c-Met, made a lot of sense. It's in the liver. And you're right in a way that it would have been, and it is actually, a very, very highly potential target. So back to you, Mike. However, there were other anti-c-Met like c-Met inhibitors, like for example tivantinib, but didn't make it, while cabozantinib did. Like, wow, your thoughts?
Well, so tivantinib is more narrowly MET focused, and I think the question is, how much of a component does MET play here? I think the additional targeting of AXL is now getting a lot of attention. That's not really a target that we thought much about in the past, but given that cabozantinib does target it, and because AXL has a number of activities, some of which do synergize well with the immune system and modulating the immune system, AXL downregulation in some preclinical models increases the immune response and increases autoimmunity against the tumor. So I think that's probably the issue here, is that these drugs that have more broad targeting seem to be the ones that are reaching the milestone of clinical utility.
Yeah, no, I totally agree with you. If anything, we know retrospectively that the tivantinib decision was to move on only with the patient with the high c-Met, and they decided for themselves that a 3 to 4 plus 50% expression of the immunostain of c-Met positivity will imply that patient will be eligible for the study. I mean, the only thing that we did with the cabozantinib is actually we allowed all patients to come on, and exactly as Mike is suggesting.